Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Today, we are going to do a quick intro to peds and OB. I've had a couple requests for this specific podcast, so we're just going to get into it. If you are starting your peds or OB clinical rotations, if you're wanting to get a jump on any didactic learning in peds and OB, like this is what we're looking for. These two specialties tend to create a lot of anxiety for SRNAs because suddenly the patients look different, the physiology is different, and everybody around you seems to be moving incredibly fast, and you seem kind of behind in that sense. You're not behind, you just need a little bit more experience. The good news is that most peds and OB anesthesia can be simplified if you understand a few physiologic properties, okay? This podcast is going to focus on the pediatric airway, pediatric physiology, pediatric pharmacology, pregnancy physiology, labor analgesia, C-sections, and OB emergencies. We're just going to do a brief overview of all of those concepts. We're going to talk about how you can use them clinically and on the NCE, on that board exam. Let's get into it. So let's dive into why pediatric patients are different, okay, from an anesthesia standpoint. Many SRNAs enter peds thinking like it's just anesthesia on smaller people. Well, it really isn't. I know we talked with Becky, who's a pediatric CRNA with a pediatric podcast that's kind of separate from this and more focused on the pediatric pharmacology. And she hates when people say this because she thinks that that's what makes pediatrics overwhelming, right? But if you think about these certain things that make peds different from adults, you'll get into less trouble. For example, the problems that get adults into trouble are often not the problems that get children into trouble. You have to think of it in that way. With adults, you have CAD, we have CHF, COPD. With kids, the things that'll get them in trouble are airway, oxygenation, congenital diseases, right? The physiology between the two patient populations is completely different. Let's talk about that airway and the differences in the pediatric airway. And this is a board's favorite and a clinical preceptor question asking favorite. So what is different about the pediatric patient and the pediatric airway specifically? What is different is they have a large occiput, right? The positioning of airway manipulation is going to be different. They have a large tongue, that macroglossia, right? Not necessarily in that macroglossia way that we see in adults, but in terms of the ratio of how big their mouth is versus how big their tongue is, you're going to have that large tongue. They may have a more cephalad larynx, right, which makes them a little bit more anterior on direct laryngoscopy. They have that what we call the omega epiglottis. That omega shape in the Greek letters is exactly what the epiglottis looks like, that floppy epiglottis, right? And then a smaller airway diameter, which makes sense because they're smaller people, right? They have that smaller airway diameter, which can get them into trouble a lot quicker than our adult patients. Clinical question here. Why does 1 millimeter of edema matter? Poussey's law should be your answer, right? Resistance is inversely proportional to the radius raised to the fourth power. This is taking you back to your gas law lecture. I know that everybody loves, but this basically means that 1 millimeter of swelling in an infant airway is extremely enormous. This is why croup is very dangerous, airway trauma matters, and multiple intubation attempts are problematic. We all know that our first DL is our best DL, right? And this is why, back to that Poussey's law and those gas laws, and airway edema in a smaller radius of an airway makes a huge difference in our peds patients. Let's do a quick NCE question example on this. An infant develops stridor following extubation. Why? Because the patient's airway is already small, and that small change becomes that huge problem. Right? And knowing that the stridor post-extubation can be from that swelling and causing issues in that pediatric patient very quickly. The next topic we'll dive into here is oxygen consumption and FRC in our pediatric patient, right? This is a really high-yield pediatric concept. In adults, the oxygen consumption is about 3 mLs per kilogram per minute, okay? And different textbooks will give you different numbers, so don't focus on that number specifically, but about 3, right, mLs per kilogram per minute. Whereas in infants, the oxygen consumption can be 6 to 8 mLs per kilogram per minute. And at the same time, these pediatric patients have a lower FRC, that functional residual capacity, right, within their lungs. Translation, what does this mean? They consume oxygen faster and store less oxygen. Clinically speaking, desaturation happens incredibly fast. This explains why in our pediatric patients that mask ventilation matters, right? I always tell brand new SRNAs that are starting clinical that you'll learn how to intubate, but bag mask ventilation is important because it gives you more time if you had an unanticipated difficult airway, right? Bag mask ventilation is the number one skill to learn. And also why pre-oxygenation matters, which we know can be really challenging in a pediatric patient especially, but it is important to build up that FRC. And first attempt success matters, which I've already mentioned, right? First DL, best DL, and preparing for the best possible one given your patient scenario. Now that we've talked a little bit about, their oxygen consumption and their FRC, let's talk a little bit about cardiac physiology. With adults, we compensate with, as we know, increased heart rate and increased stroke volume, right? When we have depressed cardiac function. Infants, not so much. Their myocardium is less compliant and they're heavily dependent on heart rate. This board's clinical pearl that goes along with this is that bradycardia is always hypoxia in the pediatric patient until proven otherwise. You have an infant that you're doing a general anesthesia for, that becomes bradycardic all of a sudden. We don't want to grab our atropine first. We want to ask, why could they be hypoxic? What is causing this bradycardia? We need to fix the oxygenation before we treat the bradycardia necessarily, right? Depending on what's going on. But anytime you see bradycardia in a pediatric patient, you have to think hypoxia. We have to fix that oxygenation and then the heart rate will fix itself once the patient is well oxygenated again. We're going to do a brief pediatric pharmacology overview now that we've gone over a little bit of cardiac physiology and honestly lung physiology when we talked about FRC and oxygen consumption. So let's talk about pediatric pharmacology, their MAC value, pediatric MAC value. This is a huge kind of boards topic. MAC rises after birth and peaks around 6 months. Okay, so 6 months is when their MAC is the highest and declines thereafter. So remembering that their MAC value peaks around 6 months is key. In terms of neonatal pharmacology, they have these neonates have an immature hepatic metabolism. They have an immature renal elimination and protein binding. Drug responses become unpredictable at that point, right? Because we have clearance issues and decreased protein binding, which increases that free fraction of the drug, right, intravascularly. This is why we titrate carefully in neonatal patients, which you guys will be titrating carefully in every patient once you get started in the clinical setting as it is, but specifically in the neonates for those 3 reasons. Immature hepatic metabolism, immature renal elimination, and immature or lack of protein binding. Common cases. Let's talk about clinically speaking, what are common cases we see in pediatric patients, right? Ear tubes, bilateral laryngotomy tubes, right? What are we worried about here? We're not worried about heart failure, right? Like some of our adult patients, we're not worried about sepsis. We are worried about airway, specifically laryngospasms, bronchospasms, and then emergence delirium. These tend to be very short cases, and we don't tend to even intubate these patients or put IVs in these patients because they are so quick. We put the patients to sleep with the mask. We ventilate them through that mask throughout the anesthetic, and then we wake them up at the end of the procedure. What comes into play with these cases are we need to have all of our IM medications ready to go, right? Because I said this patient's not going to have an IV, which seems really uncomfortable for everyone working in the hospital, but this is how we do these cases. So having IM Toradol is something that we give for pain relief sometimes for these ear tubes, and all of our IM emergency medications, our atropine, our succinylcholine. Those medications need to be ready for every pediatric patient case, but specifically these because they are not going to have an IV and your likelihood to use them is higher. The next most common case that we see in the operating room with pediatric patients is tonsillectomy, right? The most important comorbidity with tonsillectomy patients is OSA, right? They have these huge tonsils. They have this history of OSA. We need to remember that those patients specifically are opioid sensitive, For our tonsillectomies at facilities that I've worked in the past, we actually do a non-opioid approach, which if you've listened to any of my lectures, I'm a huge proponent for non-narcotic anesthetics in general. But these in particular, we used to give we used to give half of a microgram per kilogram of Precedex, and the patients were really sleepy in recovery. We actually cut it back to a 0.25 micrograms per kilogram for these patients IV, and no opioids in general. And they go home on Tylenol and Motrin, so they tend to do really well with that. Remembering that they are very opioid sensitive and planning and tailoring your anesthetic accordingly. We hit the heavy hitters in terms of NCE boards type of high yield pediatric concepts, as well as went through a couple of clinical scenarios that you will definitely see the second you start doing pediatric anesthesia, that ear tubes, tonsils type picture. So let's dive into OB anesthesia. I do love OB anesthesia for a lot of reasons. And if you've listened to this podcast or know me, you know that that's true. But let's talk about why pregnancy changes everything, right? Pregnancy affects, I used to work with an anesthesiologist that would say pregnancy is a disease, which is true. It changes a lot about our physiology and is a disease process in a sense in that way. You say it as a joke, but it truly is a disease process when you look at how it changes physiology. A temporary one, but one nonetheless. Pregnancy affects airway, respiratory system, cardiovascular system, the GI system, and pharmacology. Every anesthetic implication stems from these changes. So first, we're going to talk about how pregnancy changes our airway. And I say our because I've been pregnant before, but I'll stop doing that. Pregnancy changes in the airway are the following main three. It causes airway edema, capillary engorgement, which kind of ties into that edema, and weight gain, right? The result of these three things and these changes in anatomy and physiology result in difficult airway risk increases, right, for this patient population, which makes sense. And a smaller tube is often required. The clinical pearl here is the airway we intubated easily at 8 weeks may not be the same at 38 weeks. If you've looked at an airway, let's say that a patient had, even from second trimester, had a general anesthetic with an intubation that was easy, it may look different at 41 weeks coming in for a crash C-section. So keeping that in mind, because there are changes even throughout the pregnancy. In terms of respiratory changes, pregnant patients hyperventilate, they breathe faster, have a lower PaCO2, they have an increased oxygen consumption, which makes sense because they're growing a fetus, right? And a decreased FRC. Does this sound familiar? It's one reason OB patients desat similarly to pediatric patients, right? They have that increased oxygen consumption and decreased FRC that match pediatric patients, all resulting in quick desaturation, which is why, at least at the facility I work at, for crash C-sections, we do glide scope. We don't even attempt DL. That's controversial, I know, and you can do whatever you want in terms of clinical judgment, but that is our practice at our facility. We know our first shot should be our best shot, so we go with our backup plan and do glide scope. The board pearl that we'll discuss here is that normal pregnancy PaCO2 is about 30 millimeters of mercury, so not 40 like we normally have outside of pregnancy. Let's talk about some GI changes, right? I always joke that if you are answering, because Dr. John Nagelhout used to joke this, that if you have a question on boards or a test that has to do with a parturian, a pregnant patient, and it's about which hormone or which causes this change physiologically in the OB patient, if progesterone is an answer, you should pick it because progesterone is the culprit for a lot of these physiologic changes. In terms of GI changes, what causes these changes in the GI system? Everyone says together, progesterone, right? Progesterone causes a decreased LES tone, that lower esophageal sphincter tone, delayed gastric emptying, and that results in aspiration risk, right? Every pregnant patient should be treated as a potential full stomach. Aspiration risk is huge. So that's why we RSI with a glide scope for crash sections at the facility that I am affiliated with. In terms of cardiovascular changes with pregnancy, cardiac output increases, blood volume increases, and SVR decreases, but uteroplacental circulation lacks autoregulation. And that is a huge, huge concept. Why does maternal hypotension matter, right? When you place an epidural, and the most common side effect of an epidural or a spinal is that sympathectomy, right? And hypotension, one of the main side effects, I should say. So why does maternal hypotension matter? Because placental blood flow depends on maternal blood pressure. Mom's blood pressure drops, baby's perfusion drops, and babies don't like drops in perfusion, as you can imagine. So keeping mom's blood pressure adequate is very important for mom, but also for baby. Let's talk about neuraxial anesthesia for a minute. Epidurals, pros and cons of both spinal and epidural. With an epidural, the pros, the things we love about epidurals is that they're titratable, right? We can titrate them. If a C-section goes longer, we can give a little bit more in the epidural, make it last a little bit longer. Gives us that flexibility, which is the second pro to an epidural. And it's great for labor analgesia. We know that, right? Epidurals are a great way to give mom's pain relief during labor. Spinal, pros to a spinal, you can get a dense block with a fast onset. You don't have to wait that about 30 minutes that it may take for that bupivacaine to set up in an epidural, right? The cons, however, to a spinal is hypotension, right? That immediate sympathectomy that can happen. A combined spinal epidural is kind of a board's favorite, right? It's a fast onset, plus you have the flexibility. A combined spinal epidural, for those of us who've never been exposed to a CSE, as it's called, essentially you place an epidural, but once you get into that epidural space and get that loss of resistance, you stick a spinal needle through your TUI needle, puncture the dura. You can either just puncture the dura. There's been some literature to show that in and of itself causes some analgesia, or you can give a little bit of narcotic in the intrathecal space or a little bit of bupivacaine, depending on how far along a mom may be. Some reasons you may do a CSE would be imminent labor, right? Imminent delivery, rather. Imminent delivery would be a reason to do a CSE. There's many different reasons to do this, but if you want the rapid onset of the epidural, that would be something that you could do. You could do a CSE, which is a great option. Why does spinal hypotension occur? We kind of mentioned this sympathectomy, right? We have that sympathetic blockade. We have venous pooling, reduced preload, reduced cardiac output, which results in reduced placental perfusion. All of this happens because of the spinal hypotension and causes that spinal hypotension, right, from that sympathetic blockade. We know that the cardio accelerator fibers are our T1 through 4, right? And that's when you'll get that hypotension once the spinal starts to take out those cardio accelerator fibers. What is the main treatment in terms of pharmacology for spinal hypotension? The current board's answer for this would be phenylephrine, not ephedrine. Ephedrine has been associated with some fetal acidosis. In the past, phenylephrine was not recommended because they thought that alpha-1 vasoconstriction decreased uteral placental blood flow, right? Would clamp down and you wouldn't get that perfusion to the uterus and to the placenta and to the baby. But we've gone away from that literature-wise, and we are now saying that the fetal acidosis associated with ephedrine makes it the less desirable choice. So phenylephrine is the correct answer currently for treatment of spinal hypotension. So we've talked a lot about OB, pathophysiology, pharmacology, physiology. Let's talk about some OB emergencies that are heavy, high yield for boards, and then you need to be prepared to manage in the clinical setting. First is high spinal, right? Symptoms of high spinal: dyspnea, difficulty breathing, hypotension, bradycardia due to those cardio accelerator fibers, right? And then loss of consciousness. Our priorities here, right, are airway management and ventilation, and then vasopressors in that order, right? We need to manage the airway if the patient's no longer able to maintain their own airway. A quick anecdote about that: Dr. Sash Elijah, when I was in his class, had discussed his experience with a high spinal, which I've never seen clinically. And he said that the patient got their spinal, started coughing, and the CRNA was like, stop coughing, stop coughing. That coughing and that increased intrathoracic pressure can cause your spinal to go higher. And so the patient did fall unconscious, and the provider took over the airway. And he remembered how amazed he was as a student watching that all occur. So I like to share that anecdote because I've kept it with me as well. The next emergency we'll talk about is local anesthetic systemic toxicity during OB. Remember that epidural catheters can migrate and patients receive large local anesthetic doses. So those two things together mean that we need to be able to recognize LAST quickly. The signs and symptoms of LAST we'll go over. I've done other lectures on LAST, but we need to be able to recognize that tinnitus, the ringing in the ears, the metallic taste in their mouth, seizures eventually, and cardiovascular collapse can occur on the extreme of LAST. And the treatment for local anesthetic systemic toxicity, lipid emulsion, right? We always have our LAST kit on every unit where you're doing regional or OB so that we're able to administer lipids quickly to patients. And ours is on top of our difficult airway cart, I believe, at our facilities. Lay eyes on your LAST emergency kit when you can, just so you know where it is. The last emergency that is common in the OB population is postpartum hemorrhage. We have to know our drugs and what is first line, second line, and what contraindications are associated. Oxytocin or Pitocin is our first line, right? Every patient that comes in gets Pitocin post-delivery for decreasing risk of postpartum hemorrhage. The next is Methergin, right? Methergin is our next uterotonic. Utero, you think of uterus, tonic, contraction, right? And we want that uterus to contract and get really small, which is why nurses are massaging the fundus, remember from nursing school, massaging those fundi. You're not going to do that as an anesthetist, but they will be doing that. Methergin, we want to avoid in patients with hypertension. Methergin, hypertension. Any patients with a history of preeclampsia, eclampsia, we're not giving this to those patients. The next is Hemabate. Carboprost is the other name for Hemabate. We want to avoid in asthmatic patients. Classic NCE boards type questions. Methergin, avoiding in patients with hypertension, and Hemabate or carboprost in patients with asthma. Those are classic NCE questions and clinical preceptor questions, and something that you need to know. Those are the contraindications for those medications. We do not give in those specific diagnoses for patients. We're going to do rapid fire pearls, NCE boards pearls, just to review everything that we've gone over and talked about today in this podcast. For pediatric patients, bradycardia equals hypoxia. Pediatric patients have a large tongue and a small airway. We think Poussey's law, right? MAC is highest around 6 months. And they also have rapid desaturation, right? Increase oxygen consumption, decrease FRC, desat quick. And for our OB patients, rapid fire, full stomach, right? Difficult airway potentially. Phenylephrine as the first line vasopressor. Placental flow depends on maternal blood pressure, right? Methergin, avoid in patients, parturients with hypertension. And carboprost or Hemabate, we avoid in asthmatics. That is rapid fire. Quick little summary of the things to know about peds and OB if you're just getting started. If you're about to start your first peds or OB rotation, don't try to memorize every syndrome. Instead, ask, why does this patient get into trouble? Most of the time, the answer is in the physiology. If you understand the physiology, the pharmacology suddenly makes sense. Thank you for listening. Thank you for being a favorite learner, and we'll see you next time.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.